Thank you, and it's great to be here. I have a few disclosures first, and none of these disclosures are the money kind of disclosures, so, but that's the life of a general pediatrician. I am not a bioethicist, would be my first disclosure, and I'm a little bit out of my comfort zone in talking about giving a case and then talking about the ethical implications of a case. So bear with me, and I think this will be an interesting discussion once we get to the panel piece around really how cultural issues affect primary care and in our discussions with parents. So. I want to talk mostly, and I'm just going to check my time here so that I stay on time. I want to talk mostly about something that is really essential in most of our primary care visits with parents. And so as general pediatricians, pediatric nurse practitioners, PAs, family medicine docs, in primary care, when we're seeing a family for a well child care visit, we spend a lot of the time and a lot of the focus on something called anticipatory guidance. Most people in this room will know what that is. It's really the education, the guidance, and the counseling we provide to families on something that is probably the most culturally relevant topic that they can deal with, and that's parenting. So essentially what we're doing as providers is telling parents how we think they should parent, right? And they have their own cultural beliefs around parenting. They have created their own family beliefs around parenting. And oftentimes, as we're giving this anticipatory guidance as providers, it may even be done by providers who aren't parents themselves and have not done any of the things that we're actually giving advice on. And I can attest to this as a resident. I was taught how to talk about feeding and sleeping and toilet training, and I talked about it like I'm a true expert. And then I had twins in fellowship. And I was like, whoa, I cannot believe I gave parents that kind of advice for that many years. So I changed a lot of my guidance after doing it myself. The other thing that makes it, I think, somewhat challenging is that regardless, we're usually going to be, or almost always going to have a different cultural parenting idea than the parents that we're giving counseling to. And it's not, I'm not talking about just that the lack of cultural diversity in our pediatric workforce, right? That's one thing. But I'm also talking about even when the cultures are the same, even when there's cultural concordance, as providers, we belong to now another culture. So our parenting beliefs, regardless of the culture and family that we grew up in and were raised in, our parenting beliefs are now highly influenced by the culture of Western medicine. And so that puts us at odds with almost every, it presents a cultural clash with almost every parent encounter that we're gonna have. So then I wanna talk about, for this case, really an idea of, an example of what kind of approach we can take when we are from a different culture, from a different belief system around parenting. How can we provide that parenting advice to parents knowing how culturally personal it is to them? We'll use infant sleep practices today as an example for this kind of discussion. And I think that infant sleep practices is a really nice example of how to do this kind of anticipatory guidance discussion with families when there's, as always, a cultural clash for a few reasons. First, the guidelines, national guidelines on sleep safety are really clear, and they are related to SIDS, sudden infant death syndrome. So we have clear guidelines, we have a clear reason for the guidelines, which makes it very different than talking about something like toilet training. There's a wide cultural variation, both intra and extra, right? So what I mean by that is across pretty much any race, ethnicity, any family structure, you're going to find differences in families on how they believe that they should put their infants to sleep, what the infant sleep practices are. So no matter where you practice, no matter what cultural groups you're seeing in your population, this is going to come up. We have a small window of time to intervene when we're talking about sleep safety in particular. So it's not something that we can slowly get parents to move along over a year or two, because after a year, it's irrelevant when we're talking about preventing SIDS deaths. And I think it's also, for me at least, talking to a group of folks with expertise and experience and interest in bioethics, it's an easy case for me to discuss with you because it's something that I see all the time. And I feel like it's easy to digest and easy to talk about. So with that, I want to talk about these cases. The other thing I'll mention about sleep safety and discussions of sleep safety is, so in my work, I'm working on we have a randomized control trial where we have clinical practices at federally qualified health centers, and we are using a health educator, which we call a parent coach, to do a lot of that anticipatory guidance for the 0 to 3 population. Because we believe that a lot of that anticipatory guidance doesn't necessarily and shouldn't necessarily be done by the pediatrician. So we have a health educator who talks to families, and over the past really 3 weeks now, I've been training the health educators up here in Tacoma, actually, at a federally qualified health center, and then in Los Angeles, too. And as we are training them to really do the anticipatory guidance, we do a lot of mock visits. And whenever there's the sleep, we keep coming back to the sleep because these are not clinical providers, right? They're health educators with mostly a background in either health education or case management. And they are trying to figure out, these are important guidelines that are meant to reduce SIDS, sudden infant death syndrome. But I also see that the parent that you're depicting in the mock visit is really focused on a different way of sleep. And how do we really bring those two together? So I've done it's been a lot of in my head thinking about this for a while now. So just a little bit of background, since we're going to talk about the infant sleep practices as a case study, is just we start off with these American Academy of Pediatric Guidelines for safe sleep. And you're probably familiar with them. Back in the 90s, I think 1994, started with the Back to Sleep campaign, which is really putting the baby on the back and not prone to sleep. And so the new safe sleep guidelines are a little bit more than just back to sleep. So it's the back to sleep through age 1, that the infant should be sleeping on a firm sleep surface that is their own sleep area, like a crib or a bassinet. And the other interesting thing that's added to this, to the recommendations now, is room sharing, in that there's some thought that SIDS is decreased for parents who sleep in the same room as a child. This, I think, the last one is a little controversial. Back to sleep and is less so. But that room sharing, not bed sharing. Bed sharing is not part of the recommendations, obviously. But the room sharing is a little bit controversial because although it's not super clear, but there's a thought that it does, when they're in the same room, there's a reduction in SIDS. There's a recent study that actually compared families in the first several months of life that did room sharing versus had the infant in a separate room. And as probably most parents or aunties and uncles in the room can relate to, the families that did room sharing had less sleep. So that's a really hard recommendation to do. I kind of skipped that one. So I'm going to talk just about first 2 cases, and then I'll talk about sort of the approach I think that we can take to thinking about this kind of discussion that we have with parents when there's a culture clash. So the first one is the 38-year-old mom of 3. So she's done this before, and she has a 2-month-old infant who's here for, coming to the primary care provider for a 2-month visit. She is co-sleeping, bed sharing with the infant in bed, in her bed. Usually it's the mom and dad and the baby in the bed. The other two kids usually don't come in the bed. They sleep in another room. And when asked, the mother really just prefers to have the baby in the bed with her. They do have a crib, and the baby does have her own room. But she prefers the baby in the bed. She's going to go back to work in another 4 weeks and really feels like it's an important time for her to bond with the baby. She's from this country, but her parents are not. And their cultural sort of background is that you really wouldn't put a baby in a separate room from the parent. The woman in this picture, I don't know her ethnicity from the picture, but I will say in both of these cases, the person that's depicted could appear white, but that's really just a remnant of Google images not being culturally diverse and thinking that women who sleep in the bed with their babies and breastfeed are all white. But she could be of color, absolutely. So she likes it. It's convenient for breastfeeding, rather than in 2 months, the baby's waking up every 3 hours to breastfeed. So she could get up out of bed, walk across the entire house to the baby's room, get the baby, breastfeed the baby, and then get back to sleep. But she's not doing that. She has a baby right there and is just going to breastfeed her when she wakes up at night. And she gets better sleep that way. She feels comfy in the bed with the baby and just really feels like it's a good time to bond with the baby. So that's a way that she has and her family have decided to sleep with the infant. The second case is, you could see a little personal. I have twins. And so this mom is 24, and she has baby boy twins. They are 6 months of age, and she's stressed. She does not sleep. The babies do wake up every 2 to 3 hours to breastfeed, even still that they're now 6 months. She has been told, all her friends who have a 6-month-old or anyone she talks to has told her that by most 6 months, old babies sleep through the night. Hers are not. And even though they're waking up every 2 to 3 hours, doesn't mean she's getting 2 hours of sleep because there are 2 of them, and they are not aligned on their wake-up times. So she's getting 0 sleep. They were also in the NICU for the first 3 weeks of their lives. And in the NICU, they slept on their bellies. So when she brought them home, she really felt like that was the best way that they would fall asleep. When she puts them on their back to sleep, from the beginning, they kind of startled and would wake up very easily. And it's just an easier place for her to have the babies in the bed with her. So they sleep prone, not on their back, in the bed with her. She has a history of depression from before she had the babies, and she is currently seeing a therapist for postpartum depression. She's not on any medication for depression at this time. In her social determinants of screening, the primary care provider elicits food and housing insecurity. She's having a hard time making it month to month with rent and doesn't always know at least where her meal is coming from, although she's able to get the resources she needs for the babies from WIC. So that's her situation. I'm going to go back to the title slide to discuss these cases. So I think I want to start with the approach to kind of how at least I tend to think about providing general anticipatory guidance when there's something I want the parent to do a little bit differently, or want to suggest that there's something that they could do a little bit differently in the parenting practices. So I think the general approach that I take for anticipatory guidance is first, especially when it's a challenging situation, just acknowledge to the parent that, yeah, it's challenging, they're sleepy, they're stressed, it's hard, and kind of normalize that in a way. I think a lot of parents sometimes feel like they're the only one in this situation, the only one feeling the pain. The next thing is, and when I can, and I think most providers will try to do this, is when you acknowledge the challenge, if there's something to say, wow, you're really doing a great job on this or that, to acknowledge that as well, and kind of congratulate the parent on whatever they're doing that is a positive thing. And sometimes they're small things, but important to recognize. Then ask for some details on what's going on in the story. So you might get from that first mom, the case 1, more information about maybe the crib is just too far away from the bed, and that's why she has her in the bed. For sleep, you may get some more information about whether or not that co-sleeping, the bed sharing, is reactive, or it's really just the way that they want to do it regardless. Reactive meaning that there's a reason the baby would have been in their own sleep space, but it's too far away, but they wake up. Versus a parent that has always thought that bed sharing, regardless of how the baby's doing, is the best way to practice the infant's sleep. Then provide the guidance. Check for understanding and maybe agreement on whether or not they want to try something different. And then create a plan for following up on whatever that thing that they're going to do is. So that's kind of the general approach. And then in terms of the safe infant sleep practices around safe sleep, I think the first thing for both of these moms would be to really let them know what's the first level of the safe sleep recommendations. So you may not present it as a recommendation, but just what we know is the safest way for babies to sleep, right? In their own sleep space, on their back, firm surface. So that's just the real basic piece. So I think most providers will at least give, we'll start there, that these are the ways that we know for safe sleep. There's other things included, like not having smokers in the household. Tobacco smoke can increase the rate of SIDS as well. So those kind of things. So just what we know for sure, what is a recommendation in terms of safe sleep. Now, if you could stop there, and the parent knows, okay, my sleep practices are a little bit different than the recommendation of the safest way to sleep. Or you could go on a little bit and then try to figure out, are there some alternatives that can help us rethink the way that this standard of safe sleep is, and adjust it to the parent's needs. So if you just stop at the safe sleep recommendations, you're pretty far away from where the parent is in their sort of sleep practices. And these babies in these cases were 2 months and 6 months. So you could kind of get the flavor that you're going to give these sleep recommendations, and the 2 months, I mean, they're far apart, right? The recommendations and then their sleep practices. And so you can just give them and see, okay, is a mom going to come way over here to my side? Probably not, right? Especially based on the way I presented the cases, there's lots of other reasons why they're doing what they are doing. And a lot of it is self-preservation. And so then our next step is, well, where can we kind of start moving? We're not moving even the standard of care yet. We're not changing the sleep guidelines, but we're trying to adjust it so that it fits better with the mom's practices. So an example of that might be, let's say for the first case, mother, can we think about a co-sleeper? So there are cribs that actually are meant to sit up right up against the bed and stay level with the bed. So it's like an extension of the bed, but the baby has their own safe sleep space. It is as safe as a crib, and it's in the guidelines. So that would be perfectly fine. She could still have the baby in the bed, but have a safe sleep surface, which is basically a crib that attaches to the edge of the bed. So that's one way to keep the recommendations. You're still right along with the recommendations, but trying to find a way for the parent to kind of come over to that side. But, maybe mom's like, I really want the baby in the bed with me. I understand. I know. I've seen the co-sleepers. I will have the baby in the bed with me. And you understand that that is what she wants to do. So then that's the next level. So we got through 2 levels. One is, these are the recommendations. This is the way that we do things. Then the next level is, okay, maybe we can try to not change those standards or those recommendations, but have them fit better into your life and your practices. And the third way is realizing that, okay, none of those 2 options are really gonna move you at all. How can I come more over to your side and make what you're doing and the way that you wanna do things as safe as possible and meet the safe sleep guidelines as closely as we can? It's not gonna be the safe sleep guidelines, right? So you're already kind of almost abandoning that. They know what it is, so anytime they want, they can come over to it. But really going to their side and saying, what can I do to understand that these are your infant sleep practices, and how can we make it as safe as possible? So what that looks like, the mom here in the picture, she's on a nice, comfy, soft pillow. She's got a big, beautiful duvet cover, right, over her comforter. It's all fluffy and nice for her. But that is not the way that you would set up a crib, right? So you've got some risk right there. So the first thing some providers might do is say, well, let's make your bed as similar to a crib environment as possible. Get rid of the comforter. The pillow really needs to be just under your head and as far away from the baby as possible. Even if you don't have a pillow, that would be the best. So you just have a one fitted sheet and maybe a really light sheet on top. You can, if it's cold at night, you can dress yourself more warmly and the baby in maybe just one layer of a baby blanket, a wearable baby blanket. Or swaddle the baby. So those ways to make the as safe as possible as a crib-like environment. Maybe that she has a headboard and that headboard needs to be removed to avoid the problem of that space between the mattress and the headboard and the baby rolling over and getting stuck. A space between the bed and the wall could be an issue. Is a mom a smoker? Can that help reduce the risk of SIDS? Is she taking Ambien to help her sleep at night? That will increase the risk of perhaps rolling over or suffocation. Are the 2 older toddlers jumping into bed later? That's a risk. So really helping to look at what are the other risks around that we can really reduce and make it your way of doing things as safe as possible. And in terms of the mom with the twins, really kind of maybe stepping back and addressing helping address some of those stressors, right? Because it's really hard to do things. It sounds like this mom maybe is this co-sleeping, the bed sharing is more reactive. And reactive in a sense that she's kind of at her edge of stress and depression. And so really treating all those other things so that she can do the best in terms of sleep safety for her infants, but still providing some of those things to make it as safe as possible too. So those are the kind of 3 levels of approach, I think. Some of the challenges to point out would be, first, this idea of risk and benefits. So we have our safe sleep recommendations. We know what they are. But then we also have the other issues to deal with in terms of maternal mental health. Sleep is a big part of mental health. It's really hard to work on your mental health when you're going on 2 hours of sleep a night. And so being able to recognize what is the parent doing to preserve as much as they can their mental health, and am I giving recommendations and advice that's going to tip them over a little bit to the edge? Maybe it's a colicky baby, right? And I mean, you're going to be at the mom is at the point of either this baby is is so colicky and I'm not getting any rest, and that mom's maybe putting the baby prone to sleep because she feels like she sleeps better that way. And while we know back to sleep is better than prone, maybe that mom is doing it for her own self-preservation, right? So you have to, weigh those risks. Is a shaken baby better than a baby sleeping prone? I don't know, right? So those are just the questions. I think there's no right answers anywhere. We talked about the preference, a true preference for their sleep practices versus a reactive sleep practice. And the reactive ones to really to understand that what the parent will need is us to respond to what they're reacting to, and versus just giving the recommendations in a vacuum. And then the other thing is when we talk about, we know how the parent, particularly maybe this parent here who's more stressed and isolated, is already having a lot of stressors on her. And so the way that we approach that recommendation could actually increase her anxiety and stress and guilt, right? So I'm really doing that. She already feels like she's doing a terrible job with the twins. She's isolated. She's depressed. She can't make ends meet. And on top of that, the pediatrician just told me that I'm basically increasing the risk that my babies are going to die in the middle of the night in their sleep. So those are the things that I think we have to be sensitive to when we're giving those kinds of recommendations.